Hello, Dr. Childress here with you. And in this Facebook Live, I want to discuss the Rorschach ink blot test. Let me get rid of that. Why am I discussing the Rorschach in the middle of child custody and family conflict kind of situation? Well, it's because um, as a expert witness, I'm entering the court system now, and I've been able to review over the last decade or so, as an expert consultant and witness, a number of forensic child custody evaluations. So I get to see what's actually being done in custody evaluations, and it leaves much to be desired in terms of assessment. So I wanted to discuss that with you, and I thought I would use the entry of the Rorschach, partly because I have a cat who's a little Rorschach ink blot test. I have a friend who, that's my cat. Drew a little drawing of my cat here as an ink blot because you'd actually have to fold my cat in half to make the ink blot. At this point, he's only half an ink blot. And how appropriate I thought that a psychologist would get a cat who's an ink blot. And since I got a cat, I went out and actually bought the Rorschach ink blot cards. Now, I don't have these or didn't have these prior to this. I had given up most of my testing material over the course of time. Uh, but I like the Rorschach. I miss the cards. And since I have a cat, I thought I'd get the ink blot cards again and talk about assessment and assessment practices more generally. The child custody evaluations, I've seen two forms of, well, custody evaluation is itself an assessment. And so it is subject to all the requirements and principles of an assessment procedure. And in terms of assessment, clinical psychologists are the ones who know all about that and do that. That's our specialty, is clinical psychology, is assessment. For medication, you would go to a MD psychiatrist. They go to med school, and medications is their specialty. For therapy, it's typically the master's level therapist. We train them to sort of be our frontline mental health people. So there's a more master's level. It only takes 2 years and a year of internship versus 4 years and 2 years of supervised internship for a doctorate. And so it's more readily available for people to become master's level therapists and enter the job market. And so most of the frontline staff you will see is master's level. They're not allowed to do assessment. They're not trained in assessment. Um, and then we have the medical, the social workers, MSWs, don't really get much training at all in therapy. They mostly get social work kinds of degrees. The In the psychologist domain, the that's our world is assessment. That's what we guard almost is our specialty practice. There are three qualification categories when you buy an assessment. So this one is considered a C. This requires a doctorate degree. MMPI would require a doctorate degree. The intelligence tests would require a doctorate degree. And I'm trained in all of those. I deliver all of those. And when I purchased the Rorschach, it's from a company, PAR. There's a couple, PAR. And they sent me their little brochure that has all their assessment instruments in here. And one of the fun things I got to do one time, when I got hired as director for this treatment center, I was given sort of carte blanche to buy whatever assessment instruments I needed for these kids 0 to 5 who were in the foster care system. So we're dealing with trauma, attachment trauma, autism spectrum, ADHD kinds of stuff, cognitive delays, a number of issues. So I got to go through a number of catalogs and pick out the tests that I needed for that. And that was a whole lot of fun. As psychologists, that's our specialty. We're trained in both how to administer the test, but also how to construct them. These are psychologists who go into the test construction here. So we're trained in that as well. Um, and there are certain principles by which we do assessment that are substantially violated in the forensic psychology assessment evaluation. So, as a totality, the child custody evaluation as an assessment is valid and it's basically worthless. Um, Within the psych assessments, sometimes, though, you will see standardized assessments like the Rorschach or the MMPI personality tests. A lot of times we'll do a normal range personality, NPO, PI, normal kind of range personality test. Then just a lot of times parent report scales, parent stress index, or various symptom scales that are, again, pretty pointless. Occasionally, I've seen an MCI, a personality disorder test, and I want to, and those are contained within the custody evaluation. There's a section that they do those after the long narrative of what everybody says. They do a little testing assessment, and then they go on to the recommendations. Um, in addition, I've seen another version of this where they do the child custody evaluation and they refer out the assessment for the parents. And so I get an assessment report having to do with each of the parents from some independent psychologist. And those are actually very good. I've had about three of those I've seen, three of them, that have been exceptionally good, particularly on the Rorschach. And that's why I kind of highlighted this, is in the assessments that I've seen of the parents, the MMPI does not pick up the pathology. Um, it's too insensitive. Interestingly, neither does the MCMI. Those two don't really pick up. Normal personality doesn't pick up much of anything. And so the assessments don't really identify anything about the pathology, which is one of the problems is when the custody evaluation does these assessments, they're kind of just done rote. And I have worries about that because that's kind of exploiting. If there's no value in it, you're spending the client's money for no value. And there's no reason to believe in a lot of cases that the MMPI or these other tests are going to show anything. So there's no really point or give any additional information. So there's really no point in doing the testing. Plus, they typically get back these computerized interpretations, so they report on that. You can recognize a computerized interpretation of the MMPI or something. Rarely see a Rorschach in the actual custody evaluation. It's the MMPI. It's the more objective test. Because the Rorschach takes a long time to do and score and a high level of skill. So you don't see them in that. But in the ones they refer out, these are not forensic psychologists, these are clinical psychologists doing a personality assessment. So they'll do an MMPI, occasionally MCMI, and the Rorschach. And the Rorschach is kind of interesting. Now, it used to be you weren't allowed to see these cards, but now they're up all over the internet. Apparently, there was a lawsuit that had to disclose them. The concern is that people will practice giving their responses, and so it becomes biased, and so you don't want to show them the stimuli cards. But I don't know, practicing for an ink blot test is kind of odd. What I've seen though with the good psychological testing is that the MMPI still doesn't pick up the pathology, gets close, but the Rorschach does when administered and interpreted well, it'll pick things up. The problem with the Rorschach and doing it is it takes so god awful long. You have to administer the cards. What does this look like? What does this look? And take down everything the person says word for word, because you're going to have to go back and score it like word for word, almost. And so a lot of times there's a shorthand that you do as you go along real fast to make the transcript, or you can tape record and send it out, get a transcript back, and then you have to go through all the scoring interpretation. Okay, here's the Rorschach book. Okay. Now I like the Rorschach, so I kept the book. Um, here's the book, and here's the scoring book. Okay, so we have a book that describes this, and the scoring book is just like an absolute nightmare to try to go through and score how each little detail of how the person constructed their imagery of what they saw on the ink blot. So for somebody like me, who I've done it, and but I'm not at the higher level of doing it frequently enough to become really skilled. It can take like 12 hours or something from start to finish to produce a Rorschach. And if you give me 12 hours of clinical interviews, I can produce the quality of information that I get from the Rorschach. So while it's excellent, it doesn't really give me that much more than what a clinical interview, a good clinical interview will give me. Now, one of the reasons I have not spoken so much about the formal assessment side of child custody evaluations, what they do with the MMPI and stuff, is because I'm of the opinion that all child custody evaluations should just disappear and go away. They are not well conceived. It's the whole idea of the referral question of the custody evaluation is an inappropriate referral question. And let me explain a little bit about that. So psychologists, we're the assessment people. We design, construct, and administer assessments. We're trained to do that. And so I received my training at Childress, was my supervisor in assessment. And that's where we learn psychology, is in supervision. Um, so as a supervisor, I am doing therapy with a client, but I'm using the intern as my intermediary. And in using the intern to deliver my therapy, the intern learns how to do therapy. And so that's the supervisor relationship with the interns and trainees. And so I learned from Bob Colgrove. He was pretty tough. He was an EdD, a doctorate in education. Now, they're not supposed to do therapy, but therapy is pretty common. It's what we do. So, but they're focused over on the testing, the psych assessment, because they're in the education system. So they're the top in the education. So I'm a PsyD. I'm like psychotherapy specialization. When I go into school system, the EdD would be the top one of all the doctorates over there. Then if you come over to therapy, the PsyD would be the top one. If you go over to research, the PhD is the top one. But we all do the kind of stuff, but it's just where our specific specialty was. So I received my training from an EdD in assessment. He was tough. And one of the key, first, most important things is the referral question, because you always test to the referral question. There's a reason for that. It's because everything we do is based on this normal curve thing here. And I got this whole thing memorized. I've done it so many times. And plus, I teach assessment at the graduate level, so I taught this stuff. But you'll see all this stuff about, where is it? The standard score, the scale score, T-score, percentile rank, and different percentages under different categories here. And to get significance, you have to be way out and over this tail over here, or this tail over here. Stuff is normal range. So you can be way out over here and be considered normal, or it's only this. And the reason for that is because it's called 2 standard deviations from the mean. So two standard we consider that kind of abnormal. Now, why is it 2 rather than 1.75 or something? Because we like round numbers, and so it's kind of numerology more than any rational reasons. We run into that a lot with ADHD. We have kids who are very hyperactive, but they don't quite meet the, 2 standard deviations, but boy, they got something going on. And everything's based on statistics. And so if we just go out randomly sort of saying, administer test, find out what's problem, that's not how statistics work. We're just going to get spurious results with things that just show up by chance. And um, and we wind up testing for stuff that doesn't answer anybody's questions, which is what happens over here in forensic psychology. The testing doesn't answer anybody's questions. So it is critical. Principle one that I was taught and that I teach people in assessment is your referral question. You have to get a good referral question. If you get a bad referral request to that, you're going to get bad results that are useless. Now, the client frequently will come in with a bad referral question. The school will want to know what's wrong with Johnny. Well, that's too broad. It could be 1,000 different things, and I could wind up testing for years and finding things that aren't really there just based on chance probability of statistics. So but that's what the school wants to know. What's wrong with Johnny? So what we do as psychologists, we help them frame. So you say, well, what's Johnny doing? Is it, well, they're getting like acting out during the school. I say, it doesn't happen all the time. No, it happens around like 10 or 11, late morning. Say, what's the subject? Well, we're talking about math. Okay. So then I want to know what is the reason or what's going on with Johnny around his math and his acting out. So I might be looking at a learning disability. Does Johnny have a learning disability or emotional problems relative to his behavioral acting out in class? Now that's a compact referral question. Does he have a learning disability? Does he have emotional problems? I can answer those two based on my assessment. What's wrong with Johnny is overly broad. The referral question in forensic psychology is what should the child's custody be? That's an overbroad and unanswerable referral question. There is no information in all of psychology that would allow us to answer that information. It would be based on what criteria? Well, the best interests of the child. Based on what definition? Well, we don't have a definition. Then I don't have an assessment for you. There's no criteria by which to judge the best interests, and there's no way to know what the custody should be. I'd have to predict the future and what's going to happen, and I have no idea. So that's an overbroad and unanswerable referral question right from the start. So the whole idea of custody evaluations should be gotten rid of. And so that's why I haven't talked about the assessment part, because I don't want to give the impression that there's some aspect that is working for them. But these standardized assessments are of potential value, not in the assessment, but in the research surrounding this. And I want to talk about that for a second. Because as a psychologist, assessment protocols are what I do. I develop them, administer. I've administered a huge number of tests, from the Baileys for 2-year-olds, Rorschach, all the different education ones, Kaufman, Whisk, just all those, even down to some of the DAS and some of the neuro stuff with kids, the NEPSI with kids. So I've hit the full spectrum of psych testing, and I've developed psych testing protocols not only for my tests with kids. When you get a kid out of foster care and they got some sort of problem with a 2 or 3-year-old, you don't know what it is. Is it autism? Is it neurological? Is it behavioral trauma? You develop an assessment protocol specifically for that kid. So I've done all that as a director of the clinic, kind of organized kids coming in. Plus, I was clinical director for a FEMA DOJ project to develop a national model for assessing juvenile fire setting behavior. They needed to know whether it should go juvenile justice track or mental health track, so they needed to know what was going on. Should we send the kid to the criminal justice system, or should we send the kid to mental health treatment? And so I developed that, and I put it up on my website so you can see a work product example of an assessment protocol. Now, I have developed an assessment protocol for this court-involved psychology here, the assessment of attachment-related pathology surrounding divorce. Now, this is an assessment protocol developed by a psychologist, Dr. Childress. I'm being kind. I want to make clear, there's no new theory here. Dr. Childress does not have any new theory. Okay, I apply knowledge, I don't create it. If you want to create knowledge, you go be a PhD and work in the universities. They're the ones that generate the research. I look at the research and I use that to solve pathology. I'm a PsyD. Okay, my vita is not strong on the research side, or it shouldn't be, because I've sacrificed that to get additional training in the therapy and assessment side. So in terms of like making stuff and doing assessments, PsyD is like kind of your top professional in that. If you want medication, go to a psychiatrist. If you want like therapy, go to an MA person, frontline therapy. If you want assessment, come to a psych. So, so I've done that. I've done an assessment protocol for you. Uh, I don't need to do any of these formal tests, okay, of anything to to acquire the diagnosis. And so that's the real issue. We need a diagnosis to guide our treatment. And I kept it about 50 pages, so it's real concise on this. And this can be given to the court. You say, this is what I want. This is the type of assessment protocol. Or it can be given to therapists and say, this is what I want. This is what Dr. Childress says. And so this is what now I've got it into 6 sessions here, but truth be told, I can do it in up 2, 3, 4, 5, depending on what it needs. Because for me, I do a mental status exam of thought and perception. So I need to meet with the allied parent to see what's going on, get history and symptoms. I meet with the targeted parent to get history and symptoms. And then I meet with the kid and see the MSE of start and thought perception. And in those assessment sessions, I can pretty much get the thought disorder. We don't diagnose thought disorder by history. We actually, in the mental status exam, we actually pop it out in the session and we can look at it and rate various features about it and then put it back in and close the person up again. So we elicit the delusion in our clinical interview. So, but I don't expect other people right now in forensic psychology to be at that level. So I've kind of scaffolded a system or an approach, 6 sessions whereby you can document the symptoms and get to the diagnosis. That I don't need to add any assessment. If I needed an assessment, I'd add it. Now, that doesn't mean I don't see stuff that is being missed big time over here in forensic psychology. And so that's why I wanted to do this seminar or this talk on psych testing in child custody cases. First off, the psych testing is part of the custody evaluation. Pretty much 100% of the time it's been worthless, pointless, and of no value. And the entire custody evaluation has been 100% of the time pointless, worthless, and no value. Reliability, it's just one person's opinion, and typically it's a wrong opinion. So they apply no knowledge. It's just a nightmare. However, it just bothers me as a clinical psychologist watching this stuff because the Roberts. If you want to know anything about the emotional well-being of the child or what's going on emotionally, psychologically with the child, the Roberts. It is a projective test. So similar to this with Exner scoring, this is a standardized projective test, which is very valuable. And it's got a series of cards similar to the Rorschach. But if you look at the Rorschach cards, you look at something like that and you say, okay, what's that look like? Okay, person gives an answer and then they project themselves into that. Now, here's the Roberts. Okay. And we asked the kid to make up a story. Tell me a story with a beginning, middle, and an end. Tell me what people are thinking, doing, and feeling. And so we asked them to construct the story. And we probably different cards that will elicit different types of stories. Now, obviously, a card like this is going to pull up some sort of nightmare story or anxious story. Whereas this card might get you into some discipline issues. Okay, so obviously each of these cards is pulling for certain material. That's what we say. They're pulling for certain, but that's not how we score it. We score it based on all the responses compared to normal range kids. So we're going to get some depressive responses, which are sad, or some anxious about injury and stuff. We're going to get some of those from all kids because some of these cards pull for discipline issues or sadness or anger. So all kids will be, but the kids who have depression or the kids who have anxiety are going to have a higher frequency. They're going to be up on that two standard deviation thing. And so the kids with a high number of depressive responses, well, here on the edge, then we got something. But most kids will report some degree of these symptoms and all of them. But we can also look to situations with the Roberts about like who the child turns to go to for support. Okay. And does the child turn to external resources? How does a child resolve issues? Is it a complicated resolution that shows processing, or is this sort of magical thinking that things just go away? And we have it standardized by ages. So we have 12 years old, 8 years old, 15 years old. And so we can get these stories that tell wonderful, that give us standardized data, norm data about the child's depression, anxiety, support from others, reliance on others, just a range of issues, unusual beliefs, unusual resolutions, and conceptual, how they conceptualize problems, all sorts of stuff. But as you're going through these cards, you'll get refusals. The child will be telling you stories. All of a sudden, they look at a card and say, "No story." Okay, I guess we had an issue there, didn't we? And so there's both the standardized interpretations on the scores and normed scores, but there's also the clinical interpretations just based on the stories that are generated or not generated on the card. So when I was back in the testing and doing the assessment stuff, if there was a question about the emotional well-being of the kid, absolutely I'm doing it. And I've never ever seen it even referenced or talked about anywhere in forensic psychology. And holy cow, are you kidding me? Tell me a story about oh jeez. And so, but I don't want to have them start using the Roberts in a custody evaluation. I want the custody evaluation to go away. Here's the thing. Here's what I'm bringing it up now, and because it's time to start talking about some of this stuff, which is once we get this kind of moving towards settlement of this family pathology and solving things, the solution is actually going to be moving through a pilot program for the family courts. That's my recommendation, is you want to solve it, develop a pilot program for the family courts. Develop 3 models, 3 pilot programs. You can use ABPA High Road as one. We got one. Dorsey and I put that in place right away. Got ABPA as High Road as one. And then just develop 2 more. Any ideas you want, develop 2 more pilot programs for intervention in the family courts with these families. Then you recruit university involvement to do the research component. You do evaluation research on it, and you collect the data, see what works, do that. And so that's how we solve things. You want to know what, you do research on it and collect the data and do what works. And so that pilot program is just, or a pilot program is just makes such rational, reasonable sense. That's going to happen at some point. Recruit university involvement. Now, the university, you can either have them implement and do the research, or you can have them just as a research and do implementation separately of whatever the pilot programs you develop are. If it's a big university, I'd let them do both sides of it. Smaller university, you may want to do the treatment and let them just do the evaluation research. And that's where you use the Roberts, okay, is on the evaluation research, because then that's going to give you nice data about the kids and what's happening with them. Now, for the assessment, I don't need the Roberts. Okay, I can diagnose without doing this. So if I can diagnose, I don't need this. There's no justification for it. And if it's just to do research on a fishing expedition, I need a research consent run through an IRB. So I can only do assessments that are clinically relevant. I can't do ones that are research relevant unless I have an IRB approval on it. So university involvement to do the pilot program, but then you can layer on the research measures to look at what's happening here. And that's why you have the university involvement rather than just doing the willy-nilly. And you put it with the court system, and the courts are going to get a high quality assessment, and you get a nice answers about what to do to solve things. And so I wanted to share that about the Roberts, to put that into the beginning discussion. And again, my concern, there's two concerns. One is uh, the pathology is going to initially claim that Dr. Childress has some sort of new theory, and that people, and that's not true. I have no new theory. It's Bowlby, Minuchin, Beck. It's standard knowledge. It's standard, it's standard stuff. So it's no new theory. That's going to cause confusion for a little bit. Once we get past that, I don't want people to start saying, oh, we'll just add this to a custody evaluation, because no, there's no criteria by which you make the decisions about the referral question. So the custody evaluations themselves are an absolute nightmare. The third area, or additional area, reason I wanted to present this on assessment at this point, is I wanted to highlight that as much as I slam forensic psychologists and the child custody evaluators, that doesn't mean I haven't seen some excellent psych testing come through on the parents. Um, and I just wanted to provide the feedback out there that the MMPI typically doesn't show it. The MFCMI I've never seen show personality pathology, which is kind of weird, which is why I'd like to maybe get into the research and see what's going on with that. Um, but but the Rorschach does. Okay, so but it takes a skilled interpretation, and if you're going to do the Rorschach, you have to be skilled to do it. So that's kind of redundant. Um, but I also wanted to add a couple of others to the idea, or the list of things to consider, and that would, for the juvenile fire setting. Not only did we need the protocol, I needed a way of documenting any mental health issues, because we were doing a screening triage initially to categorize them into emergency, need mental health evaluation, or curiosity, simple fire setting. So we had this triage but it had to be accurate, because we could develop liability if we say somebody's like curiosity fire setter and it turns out they burned down a building and we didn't identify them. So our screening triage had to be accurate. So we added a couple psych measures to do that. Um, One of them was a personality inventory for children, the PIC-2, uh, and that was also excellent. And I have never seen that used in any custody value. PIC-2, it's a parent report, and it produces a nice range of um, psychological functioning of the child across stuff. So it's much better than the behavioral ratings, CBCL or something. So PIC-2 should be considered if you want to just to document what each parent kind of sees as the child's functional level off of that. I guess I'll talk about this too with assessment, because this is in the assessment domain and it kills me. Um, Over in behavioral psychology, there's applied behavioral analysis used all the time with autism, but there's also functional analysis that's used all the time in the school system, because the Individuals with Education Act idea requires that before you do any behavioral intervention with a kid in school, you have to do a functional behavioral analysis, FBA. So you look at the antecedent behavior consequence and the function served by the behavior, and then you can adjust how behavior serves the same function, put in an alternate behavior, and various things you can do on a functional behavioral analysis. Now, that would be so useful used over here with these family conflicts, and would identify what the problem is. And so I'd say, oh, do a diagnostic assessment and various things. Functional behavioral analysis would do it too. what's the function served by the kid's behavior? And you look at the cue structure, there's no, it's not being cued by the targeted parent. There's no, it's stimulus control for the behavior. The cue is coming off of the allied parent that's serving the function of, and so you just work out where the function is, and then you can work out the intervention for that, altering the behaviors to make that behavior ineffective or irrelevant um, in meeting that function. So that's something that's done all the time, like all the time on IEPs in the school system. And it is like a standard behavioral assessment, functional behavior. And it's never, ever, ever used over here by these forensic psychologists, which drives me crazy. Um, so with that, I just wanted to introduce um, some of this on the assessment side of things. The closing, thinking about what I want to leave you with on this. The key issue on assessment is the referral question. If you get a bad referral question, you're going to get a bad answer, and you're not going to get anything useful. The referral question, what should the child's custody be, is really broad and unanswerable. And the idea that these forensic psychologists are accepting that as a referral question is just exploiting people. It's just taking their money and giving them worthless crap. So it needs to be narrowed down. And so the referral question that I suggest is that um, which parent is the source of pathogenic parenting, creating the child's attachment pathology, and what are the treatments? So the which parent puts you in a differential diagnosis, it's called. So I'm looking at the targeted parent, is they abusive, and I'm looking at the allied parent, is it psychological abuse? Now, either way on that, with a child rejecting a parent, I'm looking at a potential abuse diagnosis. So right away, I'm in the risk assessment zone, and so this is a high priority assessment, and it's likely producing a diagnosis of child abuse, given the child's symptoms, the referral coming in off of that. So there's duty to protect obligations. There's a whole bunch of stuff. So that's which parent is the source of pathogenic parenting. Now, pathogenic parenting is a term out of attachment because the attachment system never spontaneously dysfunctions. Because it has too much survival. It suddenly didn't attach to a parent, got eaten by a predator, those genes don't survive. So it's a very strong and resilient system. And so it never spontaneously it only becomes dysfunctional in response to really severely problematic parenting. So the parent is producing the pathology in the child, pathogenic, creating a pathology in the child. So it comes from attachment because attachment pathology is always produced by pathogenic parenting. That's a term we use all the time over there. So which parent is the source of that producing this pathology, rejection and anger and stuff? And then what are the treatment implications? What do we do about it? So not only just what it is, but and so that's a nice referral question that will give the court and everybody involved not only a clear understanding of what the parenting situation is, but also what the direction to go is on this. One of the problems of forensic psychology, one of many problems that they ran into, is they said we're different than clinical. They do treatment, we don't do treatment. Well, that's a problem because the solution is treatment. And and if you're just deciding which parent should get a child, you're not allowed to do that because you hurt people. And if you restrict any parent's time with the kid for any other reason than child abuse, then you're hurting the parent, you're hurting the child's attachment bond to that parent, and you're hurting the child because of that damaged attachment bond. So, from clinical psychology, from all psychology, the only ethical recommendation is that in the absence of child abuse, each parent should have as much time and involvement with the child as possible. And so, if there's a problem, then we put it into treatment and we fix it. We don't take children away from their parents because we think you're not being an appropriate parent. In the absence of child abuse, parents have the right to parent according to their cultural values, their personal values, and their religious values. And we can't go in there and start saying, I don't like your particular parenting, so I'm going to take your kid away. If it's not child abuse, they have a right to parent. And so, when the moment forensic psychology left clinical psychology and said they're not treatment, we do something different. Well, clinical psychology assesses, diagnoses, and treats pathology. You do something different. You don't assess, you don't diagnose, and you don't treat. What point are you? What purpose? We need to fix things. Best interest of the child. Everybody has a problem over in forensic psychology defining what the best interest of the child is because they are in totally the wrong mindset, morality, ethics. It's just, they're just wrong. And so that's the problem they have defining the best interests of the child. Clinical psychology has no problem defining the best interests of the child. It is always in the child's best interests for the family to make a successful transition to a healthy and normal range separated family after divorce. That's always in the child's best interest. So let's do that. Let's help the family develop or make the transition to a healthy separated family structure after the divorce. And that's treatment. For treatment, we need a diagnosis. The treatment for cancer is different than the treatment for diabetes. And in this case, the differential diagnosis is potentially child abuse, either from the targeted parent or the how we need a diagnosis. The failure to produce a diagnosis when the potential differential is child abuse is likely a violation of duty to protect. It's certainly a violation of all standards of practice. Diagnosis guides treatment, cancer, diabetes. How do you know if you're treating with chemotherapy or insulin if you don't have a diagnosis? There's so many things wrong. So I just wanted to talk and introduce the idea of assessment to people. Oh, one final thing. Now I remember what it was. The dark triad. Don't try to assess for the narcissistic borderline parent. You don't need that, and we don't really want to pathologize too strongly. We need a diagnosis, but ultimately we're going to fix things and treat things. So the less pathology we have to identify, the better. Unfortunately, we're going to have to identify it for the court. We need to disclose to the court what the pathology is. But as soon as we do that, everybody understands we need to bring it back down. So it's not about the parent's psychopathology. We'll call them more fragile or difficult parent or something, euphemism. The issue is how they're affecting the child. If the child's severely symptomatic, then I've got the child abuse and I'm concerned. If the child's relatively normal range, and we need an outcome measure for that, parent-child relationship rating scale. But if the child's relatively normal range, I'm okay relatively with the parent. We can put it in the treatment spectrum. But the issue for the parent is the personality pathology, narcissist borderline. I suggest moving to the dark triad and the vulnerable dark triad. It has I think, a little bit more grounded empirical base over in the personality literature. It's emerging. It has all the associated features: high conflict communication, absence of empathy, revenge qualities. It matches very well with the personality pathology over here. And for that, the assessment for that, they have some self-report measures for the dark triad, which in most cases would be okay because, yeah, somebody, are you a narcissist? And they say, yeah. That's the number one most reliable assessment for narcissistic personality is to ask them, are you a narcissist? And they say, yeah, because they don't see it as a problem. They see it as a good thing. So you just ask them. But in this case, if they know going in that that's not going to be a good answer, they'll just tell you no. So that self-report is problematic. However, there is a personality scale, the Hexaco, Hexaco. Each letter stands for a domain of its assessment. And that would be a replacement for like the NPO-PI, NEOPI, or the other personality, I think it's California or something, that general personality scale that's sometimes used. Put in the Hexaco. It's the H scale. It's honesty and humility, and it's a low H. And so if you really care about looking at the parent, You do the H scale from the Hexaco, and you look for the low H, honesty and humility, and that'd be the association with the dark triad. The if you pull out the H scale, they may be able to lose some, see some face validity in it. You'll be able to manipulate it. If you embed it, with it, give them the whole Hexaco, they won't be able to tell which questions are what, and so you'll get a likely more accurate response on that. So that I just wanted to put those other assessments into the zeitgeist, into the meme space about, particularly about doing research as this moves forward, because there's no need for them assessment. We would need a research consent run through an IRB to do these sorts of things, and that would happen most likely during a pilot program for the family courts where you get university involvement to do. So, thanks for attending to my little talk on the Rorschach, and now I'm going to go interpret my cat's back.